Well, Nikki, thanks for coming. I'm Mark Hurworth, the orthopaedic surgeon, and Nikki's joined us, who's a dietitian. And can you tell us a bit about yourself to start with?
Yeah, sure. So I'm a dietitian. I work in private practice. I've been doing that for about 20 years now. I work here at St John of God in Murdoch. And I see a range of clients with many different medical conditions, from, let's say, diabetes, irritable bowel syndrome, osteoporosis, but also a range of people with maybe eating disorders and disordered eating behaviours. So I offer quite a counselling role with people, trying to help them improve their relationship with food. And my big thing I like to do, everyone knows what they should be cutting out. I like to focus on what people should be putting into their diet. So that's my big focus.
Interesting. And you've come from a sporting background because you started with the Australian Institute of Sport, I believe. So that was a big change.
It was. I was lucky enough to get a role over at the Institute of Sport in Canberra, and that took me there for 4 years leading up to the 2000 Olympic Games. So I got to go to Sydney Olympic Games, which was fantastic fun. And I was working on mainly the food service side of things and feeding the athletes, the diet that we thought they needed for their sports. And then I came back to Perth.
So when I was at medical school, Nikki, the big emphasis was on fat, and now everything seems to have changed. Can you summarise what's happened in the last medical school was a long time ago actually, but in the last little while in terms of our understanding of diet, in terms of concepts of fat and carbs, and what's been the big change?
Yeah, I think if we look back at diets just come round as fads. I think that's what we've got to remember as number one. And we've only got 3 main macronutrients, so big nutrients, fats, carbs and proteins. So if you're wanting to devise a diet and help someone lose weight, all you need to do is cut out one of those macronutrients, and that's really what diets tend to do as a bit of a fad. So to give you a really good example, and I'm going to age myself here, as a teenager I certainly remember saying to my dad, not eating potatoes, because the women's magazines would say cut out potatoes because they were bad for you, they were the carbohydrates. And following that into the sort of end of the 80s, going into the 90s, as you said, it was like low fat. Then we moved away from those 2 fads, and then it became all about protein and, our paleo diets and those types of diets. Now we're just moving into another diet phase, which is the keto, and it's all about just eating fat, and you shouldn't be eating carbohydrates. So they'll just keep coming round in different stages. That's really all that happens. Is people are maybe trying to make diet books, or encourage people to pay them money.
Yeah. So with the fat, just the idea of the fats, which was big when I was at medical school, you sort of fat's bad.
Yep.
Carbs seem to have stepped into the breach, and now carbs are bad.
Yeah, absolutely. That's the big fad at the moment. People are either very severely restricting them or at least cutting them down. And I think that's quite dangerous for people, because we now have a lot more knowledge about, say, people's gut microbiome, so that being a big driver for people's health. And I think when people follow these very strict carbohydrate diets, what also goes out from their diet is their fibre intake. So I certainly see people in my clinic with symptoms. They'll say, I've been trying to follow this diet and cutting out carbs, but I'm getting really badly constipated. And those are the sort of symptoms that I see, and straight away I'm, yes, you're cutting out your fibre as well. So to me, that's something that I like to work on with people, is to try and get a balanced diet. You need a little bit of everything in your diet rather than cutting things out. The focus is trying to look at where someone's at the moment, what they want to work on, and just moving towards getting a better relationship with food. That's how I sort of see it. Yeah.
Why do you think we need to eat better or concentrate more on what we eat as we get older?
Sure. Well, I think if we look at some of the things that happen as we get older, so bone health changes, so people's bones generally can weaken, or we get more aches and pains in joints, knees and hips and things like that. Cognitive function, so memory loss sometimes in some people, changes in our gut health. So our whole gut tends to slow down. So I tend to see patients that will talk about reflux, abdominal bloating, constipation and or diarrhea. And generally our energy requirements slow down as well as we get older. So what we need to then focus on is we need less calories, but we need to make our diet more nutrient rich. So that becomes, the focus on making sure that people are choosing wisely from, carbohydrates, as I've already talked about, making sure they're getting their fibre. Particularly with cognitive decline, we see that there's some really good research on the essential fatty acids and brain function. So what we've seen in sort of prospective studies is that people who have a lower oily fish intake, there's increased risk of dementia and also Alzheimer's as well. So it's looking at, the types of fats that we're encouraging. And then there is some really good research looking at proteins as well. So as we age, our requirement for protein does go up. Doesn't mean that it becomes a very high protein diet, but it's definitely goes up, and looking at having a little bit of protein across the day rather than just in one big lump at one meal at the end of the day. Yeah.
Interesting. So just to go back to the supplements idea, obviously that's a huge market and there's a lot of marketing going on with supplements, and again it's fad. It seems to be fad driven.
Yeah.
Something comes up, it's disproven in a few years' time.
Mm-hmm.
What supplements would you recommend as you get older? So we're talking about vitamins, bones, joints, especially.
Yeah. When we look at, say, vitamins, so, A, C, E, D, all those sort of things, generally speaking, I think people can get it from their diet. I would like someone to come and see me and we work on their diet as number one. There's certain people that maybe have medical conditions that might benefit from a supplement if for some reason they weren't able to eat adequate intake. So let's say someone who maybe has bariatric surgery, that would be a good case. But then particularly I might look at, so we talk about joint pain. There is sort of mixed results about glycosamine, for instance. So there's different types of glycosamine. So we've got the sulfate and also the hydrochloride type. So the study's a little bit 50-50. So some studies are showing some good results that we might get some reductions in pain, but some studies are saying not. So if someone came to me, what I would say is usually you'd get the changes over about 4 weeks. So I think it's worth them giving it a go for 4 weeks, monitoring any differences in pain symptoms. If nothing's changed, it's probably worth just stopping it. So that would be one I might look at. Vitamin D, there's some research that people who have low vitamin D levels have more pain. So that would be a simple blood test through their GP, trying to rectify that. And maybe someone with rheumatoid arthritis, we might look at, say, omega-3 fatty acid supplements. But again, the research is not conclusive with them. You need quite a big dose, so you need to take about 2.7 grams, the research is showing us. So in some particular brands, that might be popping 10 capsules, and I don't know if you've seen them, they're quite big in size. So from a compliance point of view, that might not necessarily work.
So omega-3 fatty being fish oil type stuff.
Yes. So they could certainly improve that.
That's a large dose.
It is, yeah. So I would certainly look at people trying to get that in their diet. I think that's a better way of going, and personally I think it tastes better as well.
So maybe trialling glucosamine or glycosamine for 4 weeks.
Yep.
Give it a go, won't do any harm.
Yep.
And then fish oil, but quite large doses of fish oil. There's some evidence to support those things.
Yeah.
But I agree, glucosamine probably 50-50. So
yeah, and I think the better research or the better results are coming out from the glycosamine sulfate rather than the hydrochloride. Yeah.
Good to know. It seems very popular for people to be dieting, and we've talked about fads, but are there any particular problems with dieting? You've seen it all. Can you let us know?
Yeah, so I'm a dietitian that works from a non-weight focused perspective. So what that means is that we're trying to focus more on what people should focus on putting into their diet rather than just, say, jumping on the scale every day and using that as a monitor of how successfully they're going. And what we do see with people chronically dieting, I'm sure you've seen patients in your clinic, they've done every diet known to mankind, and what's tended to happen is over the years they've actually dieted themselves heavier. So we are set to defend our weight where we've reset ourselves to. So all this chronic dieting tends to do is people lose a little bit of weight, but when they come off the diet they revert back to that initial weight but gain a little bit more. So I certainly see in my clinic people are getting heavier by doing that. And it also leads to some disordered eating as well. So people get quite anxious about not being able to follow a diet 100%. They can't do the clean diet, which is another popular one at the moment. And they worry about that. They get very anxious and, that can push up our cortisol levels, which again makes us more likely to hold on to fat at the end of the day. And again, it might lead to long-term things like osteoporosis. If someone was very strict with their diet and they're not eating a nutrient-rich diet, it's low in calcium, which is quite common, that could be another issue as well.
Just to go back to the good fat versus bad fat idea and good carbs versus bad carbs, how would you classify, how do you talk to your patients about fat? What's good, what's bad, and carbs, what's good, what's bad? Obviously different people, different advice, but just broadly.
Just to sort of emphasise something, because I do a lot of work in working with people with eating disorders, or I call it disordered eating as well, we very much stay away from the word of good and bad, because that tends to build up a lot of negativity and guilt when people eat the so-called bad food. So I like to call it more, if we talk about carbohydrates, I'd focus more on fibre-rich carbohydrates. So really emphasising, really pick with maybe the brown rice over, say, a white rice, and really encourage that side of things. So same with the fats as well. I mean, we do know that there's some good evidence around people shouldn't be having diets high in saturated fat, but I think people have got that message that means that they shouldn't be eating any. So it's more just working with people to get more of a flexibility with their eating structure.
Are there certain foods that we need to eat more of and certain foods we need to eat less of as we get older, do you think?
Yeah, I certainly do, Mark. I think we need to focus more on maybe making sure that people are getting a mix at meal times. So I often talk about a division of a plate, let's say. So if you think about your plate, divide it into half, divide it into a quarter, and then a little circle in the middle. We make sure we've got a quarter of carbohydrates, quarter of protein, really mix of colourful vegetables on the plate, and then some sort of fat. So that might be talking about cooking in olive oil, good Mediterranean diet, or maybe adding avocado in a salad. So that would be my general sort of guideline for most people. If you're sort of ticking all those boxes, you're doing pretty well.
Did I hear you say that 50% was dessert? Was that what? I thought subconsciously I was waiting for you to say that.
That might be wishful thinking. Half was vegetables or salad. Yeah, the colourful vegetables or salad.
With olive oil, though, that's interesting because that seems to be back in fashion again.
Yeah.
Like a lot of olive oil can do very little harm.
Yeah.
and can only do good.
Yeah, and I think, again, that's moving away from the 1990s when fats were bad. I think all fats got put into the same basket of being bad. So people were using spray oils and minimising how much oil they were using. But, we've got really good evidence now from Mediterranean diets, which are very liberal in olive oil. They put it in everything, salads, they cook with it, dip their bread into it as like little starters for meals and things like that. There's good evidence, because those sort of populations, it's interesting because they have quite low risks of heart disease or cases of heart disease, I should say. And there's also pockets of those sort of Mediterranean countries that live to a ripe old age of 100 plus as well. So, good evidence around the Mediterranean diet. But I think, again, it's not just the olive oil. There's probably other things in there as well, like the high intake of antioxidants from fruits and vegetables, and omega-3 fats, again, come in there as well.
In a similar way, do you think butter is back in fashion and margarine's going out of fashion?
I do, yes. I see that a lot in situations, and I think that's quite fair, because as long as people aren't eating a whole pack of butter a day, they're just maybe spreading it on some toast. I think that's quite an acceptable thing to do if that's the taste that people are looking for. So yeah, definitely.
Just something I see a bit of, Nikki, with is the postmenopausal females struggling with weight, and it's different for men and women as they get older, especially in that age group. It seems that women struggle more with their weight. What is that hormonal related, and what could someone do about it from a dietary perspective? Sure.
Funny you should ask me that. I'm giving a talk on that next week here at the hospital. One of my little pet areas. It's very much hormonally driven. So as estrogen decreases over the sort of ageing process, we then, if we're going to put on fat, it tends to be more around the middle area. So most of my female clients that come and see me post about 40, 45 years will comment that, their trousers are starting to become a little bit tighter, particularly around that middle area. So you might have heard it being described as sort of apples versus pears. So they become more apple-shaped, rather than younger women tend to be more hippie and more pear-shaped. So as I said earlier on, to me the focus is not particularly on the weight loss side of things. My focus would be more on exercise would be a big thing, I think, in this age group, particularly as bone strength might be decreasing. And it's quite common for cholesterol levels to go up as well in postmenopausal women. So I think that's a great time to look at more of a healthful diet. So we might be focusing on, say, soluble fibre intake, rather than already restricting, because a lot of these women come and see me and they've done a lot of the dieting. So they've got to that stage often by the dieting process. They've got sort of heavier over the time,
So what would your advice be to someone who's going through or about to go through menopause? How would you prepare yourself for it? It can be very discouraging if you're trying to lose weight and you don't lose weight. I would get people to do a little bit of what I call eating awareness. So we do a lot of work on writing down what they're actually doing, so they can get a greater understanding of, I call it the what, when, how, where and when of eating. So we would look through all of those stages. So the why, I missed the why. A good example there would be why someone is eating. So it could be stress related, it could be boredom related, many reasons why we eat that's not hunger driven. Those are the sort of steps I would go through with people, number one, to just make them more aware. But it wouldn't be a big focus on just looking at the weight loss. I'd really be encouraging exercise if they weren't doing that. Or it might be referring them on to an exercise physiologist or a physiotherapist to look at the right type of exercise as well. Maybe they need some resistance training or some strength training as well at that sort of age. Okay. Yeah. So you've talked about the scales a few times, about ignoring the scales. Do you think it's a good idea to just ditch the scales completely?
Yes, yes. I actually get my patients to bring their scales to me, and I will quite happily get rid of them for them. Yes.
Okay.
I have a pile of them in my cupboard.
Yeah, because I think that's the most discouraging thing from my perspective. If you think you've done something good and you get on the scales and it doesn't look any different or looks worse, then that's incredibly discouraging.
And I think a good thing to think about, Mark, is it's very hard for someone to really improve their relationship with food when they're using scales as their measure. So if you just kept jumping on the scales and that's the thing that you want to change, all you're going to do with your food is keep restricting because you're not happy that it's going down. Whereas if you can just leave that be just for a while till you look at your diet and maybe improve that, maybe change your exercise so you're getting healthier internally, that's a far healthier way, because there is, again, good evidence to show that if we can let go of the scale side of things, people can actually do really good self-care. It changes that psychological negativity around I've got to lose weight, I've got to cut all these foods out, and guilt over I've had a piece of chocolate today, I feel terrible, I'll just go home and binge now and eat maybe a large amount of food. Yeah.
So maybe the outcome is not weight, it's the outcome we're looking for is a well-adjusted diet for you, exercise, because exercise makes you feel good.
Yeah. Absolutely.
What sort of exercise could just touch on that, because you've come from that exercise?
Yeah. I mean, it's not my area per se. I shouldn't take the physiotherapist role maybe, but certainly strength exercise and resistance type exercise I think is really good for people that are ageing. Because we know we do lose muscle mass as we get older, and we lose bone strength as well. So that type of exercise is really going to work on that particular area. But I think it's also important to work with people to just find something that they're actually going to do and continue to do. Because if you don't enjoy it, no one's going to continue doing it. And I think, again, there's really good research looking at people who exercise from a perspective of trying to lose weight. They go to the gym, they're pounding away, they hate it, but they're pounding away just to change those scales. They're the sort of people that probably give up, whereas the research shows us if people just go walking to meet a friend and they maybe have coffee at the end of the day and it's just something that they really enjoy, they don't see it as exercise, it's just part of their lifestyle.
Yeah. It's interesting. I don't think I've lost any weight since I started getting fit. It's just redistributed. Maybe more muscle, less fat, possibly. I hope so.
Yeah, and this is a bit of a dream, but I look forward to the day where we have this little bod pod that we can put people in and actually show them what's happening internally. So show them that endorphins are pushed up, our happy drug, and show them that that's what exercise can do for them as well. Show them what, a good diet can do for them, rather than just looking at it from a jumping on the scales and losing weight perspective.
Yeah, it can be a lonely process doing it all by yourself. What is your advice for if people are trying to get their diet right? Is there sort of a communal thing that you recommend, or obviously it's individualised, but is it better to do it together with someone else, with a group of people?
Yeah, I do encourage people to maybe share their journey with a friend, and I think that can just be maybe when people. I actually offer a free walking group, so that's more from that's a mental health improvement rather than just we're going to exercise. It's meeting, getting women together, just walking along and chatting about life. And I often joke with one of my best friends that, after we've had an hour's walk, I say, she's the best therapist for me, and I haven't actually paid her. So I'm really a good, strong advocate of getting women to do that, join together or
some
men.
kind of group activity, which is both social and also involves shedding a few calories.
Yeah, but I think again, we have to be careful. People have to get the right group. There are some groups that will flog them, and I do see clients that then get injured. I saw a lady yesterday actually that was very gung-ho, gone to a group and said, I want to be worked hard, but she's now stopped doing anything because she's injured her foot. So,
that's quite common in my practice as well, yeah. So, Nikki, just with surgery, as you get older, and particularly lower limb surgery, we generally say to people now, for knee replacements especially, that you need to get your BMI below 40. And I know that's a bit of a crude measurement, but nonetheless that's what things are measured in from the literature. And the evidence seems pretty clear that if your BMI is over 40, your risk of complications goes up significantly, so particularly infection, DVT, wound problems. How would you... what are your thoughts about that?
Yeah, I thought you might ask me that question, Mark. And I've got some evidence to sort of refute what you were just saying then. So, not that long ago, there was a really good systematic review done. So, systematic review, they look at a lot of the research that's out there and pool all the data. And this is quite a recent paper by a chap called Tashney, I believe it is. This review took, the title is Total Knee Replacement Warranted in Morbidly Obese Patients. So we're talking people with a BMI over 45. And their results found that, so they compared people who had a BMI of 27, and compared it with people who had a BMI of 45. So 27 would still be classified as slightly overweight, even though I don't like using BMI. 45, that morbidly obese category. And their results were quite, didn't surprise me, but I liked the results that came out because they looked at many things. So short-term outcome after surgery, no difference between those two groups. Long-term outcome between those two groups, long-term being greater than 14 years, so that's a reasonable time to look at, no difference between the two groups. Infection rates, and no difference between the groups. And an interesting one was looking at the need for another surgery. And there were fewer incidents of that in the people that are in the larger bodies. And I think, that's quite an interesting paper.
That's very interesting, yeah.
Yeah.
It's something that's difficult to deal with surgically. I mean, I think technically there's no doubt knees are relatively straightforward, even obese knees, but hips can be very tricky surgically, and it's a deeper joint. So an obese hip is something that's probably a step above that even. So, I guess it's anecdotal to some extent, but certainly we've introduced the BMI 40 cutoff in one hospital I work in, and that seems to have made it a bit easier from a surgical perspective. But
and you're the surgeon, Mark. I'm not going to argue with that.
But in terms of we keep an eye on our patients. We give them advice. We say, when you've hit this weight, contact us and we'll go ahead. How would you deal with that? Because often the argument we get from our patients is, well, I can't lose weight because I'm too sore, I can't exercise. It becomes a bit of a vicious circle.
I think that's it's a great conversation piece to have, but I think I do see some of these patients who are quite desperate to get their surgery and they're willing to do anything. And I guess the thing is that they often turn to is the meal replacement supplement. So they might go into something like OptiFast, which, whilst it's going to get their weight down and it's probably going to possibly get them to that BMI of 40, my concern with that is, are we then sending them into surgery in a malnourished state? Because those types of diets are quite extreme. They're less than 800 calories a day. So I think that's a really interesting one. I mean, I would like to see maybe the physios or the exercise physiologists working with these people to try and find exercises that they can do. So they're still strengthening, maybe joints.
I agree with you. I think a deconditioned patient is the worst possible So I agree, probably a closed chain exercise program. That's what we're looking at.
Yeah.
Is taking the bike home with you.
Yeah. And I think just adding to that, Mark, we've got to also consider if someone did a severe diet like an OptiFast, you do the surgery on them and they go home as soon as they get back into being able to eat, that weight loss is going to go back on so quickly. And I think that's quite harsh as well for a person they've worked quite hard and they're probably quite proud of themselves that they've got down and they've got to get the surgery. So I think that needs to be looked at as well.
Sure. So just to change just on that actually, Nikki, with in that context, my little sort of blurb that I give patients who are obese before surgery say, well, why don't you try these things? And I recommend 2 diets. I recommend Mosley's 8-week sugar diet and CSIRO 12-week diet. I'm sure you're familiar with them. What are your... Have I got it wrong? Am I in trouble?
Not in trouble. But again, you see, when someone comes to see me and they'll often say, I'm thinking of following the XYZ diet, I'll often say to them, look, do you see yourself doing that diet in a year's time? And that is the crucial question, because if you're doing something very, very restrictive, it's unlikely that they'll be following it in a year. Just, they will get really hungry and they'll have stopped it, and then some of the other consequences of feeling guilty that they didn't manage to follow the diet is an issue. When we look at some of, Michael Mosley's work, and I think some of it is interesting work, again, I'm not so keen because his diet is quite restrictive. So it's like an 800 calorie intake. And as I mentioned earlier on, we're driven to come back to our original weight. So yes, I've no doubt someone will lose weight following 800 calories if they can do that. But I don't see people maintaining that long term. And I just think that someone's going to regain weight on that. Now, you could argue if it's for surgery and you want to get them down to a weight to make the surgery safer and easier for you, that's possible. Someone who's quite motivated is going to be able to do that. Yeah.
And the CSIRO?
Yeah, CSIRO, a friend of mine actually worked on that dietary plan. Not a bad idea. It's slightly higher in protein. That was sort of their idea behind that, and there's some idea that suppresses appetite. Also really encourages fruit and vegetables in the diet, particularly different coloured vegetables. I think that's quite a healthful message to give to people. But again, I haven't seen anyone that's done it beyond about 12 weeks, which is sort of what the program says. So I think people see it as, okay, it's a 12-week program, I can hang in for 12 weeks, and then they stop at the end of 12 weeks and probably revert back to maybe what they were doing, before. Yeah, so that's where I think it comes back to individualisation and working with someone, looking at maybe some of the difficulties they have with their type of diet that they're eating, or the difficulties they have with maybe meaningful movement, as I like to call it.
Sure. With the other one of the other surgical issues is obviously osteoporosis. We see fractures, people falling over, and often females. Any particular dietary tips with preventing osteoporosis, calcium intake, that sort of thing?
Yeah, well, I think if we look at prevention, we have to step right back into the teens, if that's ever possible, because, that's when we're going to get peak bone mass development. So my worry is actually because everyone seems to be dieting at the moment, even younger people are dieting as well. And if they were going through their teens up to sort of 20s, early 20s, and they're restricting their intake, they're not going to maximise their bone health. So I do see a concern that we're going to get more people with osteoporosis as we get this ageing population. So, yeah, I think prevention would be a huge thing, and just, making sure that people are getting adequate, say, calcium, vitamin D, and magnesium's important mineral as well. So lots of fruit and vegetables. If someone's already got it, again, I think exercise is a big key to that, and looking towards the right type of exercise. But also, in these populations, making sure maybe they're on the right supplements. So I do advocate usually a calcium and vitamin D combination. And again, there's good research looking at the type of calcium. So I would tend to encourage someone to go with a calcium citrate versus a calcium caltrate, which I think is one of the common ones. Encouraging them to take the supplement at night time. There's some good research that we absorb more calcium at night, and also spreading the dose over the day. So when we look at calcium intake, the more we take on board in one dose, the less we absorb. So if we take space it out over the day, we're going to absorb more out of that calcium supplement. Yeah.
Fantastic. Just a few little trick questions, Nikki. Chocolate.
Love it.
What sort of chocolate and how much?
Whichever one you want. Yeah, your favourite.
Is that your professional advice?
That's my professional advice, yeah. And it's one of their core food groups, don't you?
Fantastic, I like that. What about coffee?
Yeah, coffee, I think in moderation. Again, what's moderation? It depends on every person. Sometimes as we age, as I mentioned right at the beginning, people get more reflux, and there has been a bit of a link when people take coffee, on an empty stomach. That can really rev up reflux. So that might be something that you looked at if that was an issue. But I don't have a number, but if you wanted me to pick a number, 3 or 4 coffees over the day, maybe if you're having that milk in there as well, you're boosting your calcium intake as well. So.
Okay, fantastic. And what about alcohol as
Good.
you get older? As you get older, unfortunately, it seems like you have to drink less.
Yeah, and again, I would advocate people look at drink safe regulations with that. So that would be 2 standard drinks for women, up to sort of 4 for males. But I think with my clients, I look at it more of why they're needing alcohol. If it's very much enjoyed as a social setting, I think that's quite a positive thing, unless they're binge drinking. But if someone was using it as an emotional crutch, lonely, or they can't see their life without alcohol, I think that might need to be managed better with someone. Yeah.
Well, thanks, Nikki, for coming, and that's been fascinating, and I think completely changed my perspective on a few things. I'm particularly happy that I can give away my scales.
Great.
And keep eating
Bring
chocolate.
them to me.
That's great. But I do think it's a very valid point that we don't need to measuring ourselves in that way is probably not the most helpful thing, and that to have a sustainable goal is much more important, and something that's social, sustainable is fantastic. So thanks. We'll leave a few links at the bottom of this interview, and thanks again for coming along.
Thank you for the invite.